Good evening, friends. So I'll be talking on this small topic, MINOCA. So I'm sure many of the listeners may not necessarily have heard this MINOCA because I was asking my trainees, few of them didn't knew. So it's good to know about this condition because we do see a lot of patients coming to ICU with this scenario. So it's not a rocket science. MINOCA is the established word. It's called myocardial infarction of non-obstructive coronary artery. So it's like something like NOMI, non-occlusive mesenteric ischemia. It's like myocardial infarction of non-obstructive coronary artery. So that is the uh, acronym for MINOCA. So wish to thank my colleague Dr. Manjunath who presented on this topic. So we need to know what is the definition of MINOCA. So MINOCA is a mimic of acute myocardial infarction. So the patient would manifest with all the symptomology or signs of myocardial infarction. So these patients will have raised troponin, they will have ST elevation, and they'll have echo features of myocardial ischemia. So I'm sure most of the listeners would know, like in patients with sepsis, very often you do troponin. Troponin may be high. You may see some ECG changes, and echo also may show some hypokinetic regions. But very often we have seen and in fact, one of our trainees doing a study on this. We send them to coronary cardiologist who says coronaries were absolutely normal. It was a stretched myocardium, and sometimes we call it as Takotsubo when there is apical ballooning. So this is the spectrum of conditions which comes as where they come with other conditions. In ICU, you will see cardiac enzymes will be high. There'll be some ECG changes. There'll be some hypokinesia, but coronary vessels will be normal. And this condition we call it as MINOCA, myocardial infarction of non-obstructive coronary artery. And the definition is this, where you have all these features, but when you do angiogram, there should be less than 50% occlusion of the coronary vessels. That is the crux of the definition. So they won't have an obstructive coronary vessel. There'll be non-significant sort of a coronary lesion. So the definition should entail less than 50% of occlusion of the coronary vessel. And very often, any ACS coming to ICU, one third has been found to be due to STEMI, and two thirds have been found to be due to non-STEMI. And generally, it is very hard to find out the overt specific cause for this MINOCA. So the key aspect in definition is presence as MI, but when you do a coronary angiogram or cardiac MRI, there should be less than 50% of the occlusion of a coronary vessel. The culprit vessel occlusion should be less than 50%. So that's the definition if you have to remember this. So what, the etiology becomes very important. So MINOCA, if it is asked in exams, it is good to know at least the salient aspect. Etiology is divided into coronary etiology, cardiac etiology, and extracardiac etiology. And the commonest cause of MINOCA is found to be due to plaque rupture. That is the commonest. Two-thirds of the causes of MINOCA is due to the plaque rupture. So coronary cause still remains the most common. So plaque rupture is the commonest cause of MINOCA. Coronary spasm, which during our medical days we have learned it as Prince metal angina, is also one of the common cause for MINOCA. And there can be due to coronary artery dissection or microvascular inflammation of the coronaries due to any vasculitis or autoimmune condition also can come under MINOCA. So, and coronary artery dissection due to any cause, due to plaque rupture again, is these are the common coronary causes of MINOCA. So cardiac cause, the commonest, I'm sure most of you see very often, we have sent our patients who come as MI to coronary, and when they come back as coronary is normal, our cardiologist always says it's due to stress myocardium. So Takotsubo cardiomyopathy or stressed myocardium is a second sort of a commoner cause of cardiac cause of MINOCA. So stress cardiomyopathy or Takotsubo, where there is apical ballooning of the myocardium of the LV apex, is typically the cardiac cause of MINOCA. And myocarditis. So any inflammatory conditions of the coronary vessels or any inflammation of the myocardium. So myocarditis is an important cause for MINOCA or any cardiac contusions or cardiac injury following any trauma and even tachyarrhythmias. So tachyarrhythmias of any nature can stress the myocardium. It can be AF with fast. So very often you would see atrial fibrillation with a fast ventricular rate, going into heart failure, behaving as myocardial dysfunction. So ventricular or SVT. So all these can act as a trigger for MINOCA. So these are some of the cardiac causes. In ICU, typically we see MINOCA in a sepsis patient. So sepsis also causes myocardial depression or myocardial dysfunction, and that is also is touted to be one of the cause for MINOCA. In ICU, the causes that are little specific ICU, even a stroke or subarachnoid hemorrhage or severe stroke causing myocardial dysfunction is a cause for MINOCA. Sepsis is the commonest cause of MINOCA in ICU, and pulmonary embolism is also attributed as a cause for MINOCA. AKI or any other severe organ dysfunction and hypoxemia, any of the ICU conditions putting stress to the myocardium causing dysfunction can manifest as MINOCA, and hypoxemia also is one of the stress in AKI. So these are some of the defined causes of MINOCA. So for all our trainees, so remember this picture. So when this is sort of contemplated this topic, put it as coronary causes, cardiac causes, and extracardiac causes as the etiology for MINOCA. So what about treatment? So then obviously you have understood MINOCA is a secondary problem due to some other primary etiology. So treatment is always based on underlying cause of the condition. So you have to determine whether it's a coronary origin, whether it is a systemic problem, or whether it is a stress due to cardiomyopathy. If it is a tachyarrhythmia, you have to correct the heart rate. If it is cardiac contusion, obviously you may have to adopt other modalities to minimize the sympathetic surges. And if it is a inflammatory conditions, you have to address it. So treating underlying cause becomes important. And there is paucity of randomized controlled trials to address this unique dimension of MINOCA and observe, but the data comes mainly from observational studies and registry data, predominantly from the SWED heart. SWED heart is a huge registry data of all the cardiac ACS patients. So where it is shown that use of AC inhibitors, so RAS inhibitors, so renin, angiotensin, aldosterone inhibitors with statins has shown to reduce mortality in MINOCA. So this is based on the registry data and observational studies. Use of AC inhibitors and ARBs with statins has shown to reduce mortality. Long-term benefit is shown with AC inhibitors and ARB based from this sweetheart registry data. Positive trends have been found with beta blockers, and dual antiplatelets not necessarily have a robust signal towards favoring good outcome, but it has had a neutral effect. So this is precisely based on the Swedheart registry data. So benefit is mainly seen with AC inhibitors or ARB, angiotensin receptor blockers, and beta blockers. So obviously, most of the listeners would know these are some of the tenets of managing any ACS or any heart failure in ICU. So that remains the case even with MINOCA. What about outcome? So again, outcome is determined based on the underlying cause. So if the coronary vessels, plaque rupture, so that has a bearing on the outcome. So mortality and major adverse cardiac events are comparable to obstructive coronary artery disease. So the outcome in MINOCA are similar to the outcomes of obstructive coronary artery disease, but mortality and major adverse cardiac events are worse when compared to general population. So as compared to general population, if someone has had a MINOCA, they have a worse outcome. So which means it is a pathological problem. It cannot be undermined or it cannot be de-emphasized because the mortality and MACE are similar to like an MI, like similar to obstructive coronary. So it has to be dealt with seriously. So the Swedheart registry has shown that 1/4 of the patients have developed major adverse cardiac events within 4 years of developing. So if you have witnessed MINOCA in ICU, they need to be followed up and they need to be treated appropriately because they are at a risk of developing major adverse cardiac events within 4 years. And the major adverse cardiac events are death and recurrent MI or hospitalization due to heart failure symptoms or stroke. So these are so which means someone who manifests with myocardial dysfunction or the MINOCA within ICU due to sepsis, due to AKI, due to hypoxemia, it portends that they are at a risk of major adverse cardiac events within 4 years, and one has to be on a follow-up with a cardiologist and on appropriate medications with beta blockers, AC inhibitors, so on and so forth. So the conclusion is a short sort of a topic, but a nice topic to keep in back of mind. It's a heterogenic working diagnosis and multimodal approach is needed. Why multimodal? So we cannot, so the whole take home message for me for this MINOCA is in ICU, if you have a raised troponin and if they have sort of ECG changes with echo findings, don't ignore. They need to be followed up with coronary angiogram, which we have done. We send patients, even if coronary vessels are normal, they need to be followed up. So the crux is don't ignore. They need to undergo coronary angiogram or cardiac MRI, and they need to be on a follow up because the risk of future mortality and morbidity will be high, and establishing the underlying cause is terribly, terribly important to address this. And as I said, two-thirds of MINOCA are due to the plaque rupture. So that needs to be kept in mind. Treatment, as I said, is empirical. So you have to lower the heart rate, you have to reduce the afterload, you have to optimize preload, so on and so forth. But we need much larger randomized controlled trials to understand MINOCA and to devise more definitive sort of a therapeutic options. So thank you one and all. So I request all my listeners and my YouTube followers to please register to JIX 2024, which we are doing it on 17th to 18th October. So it will be one of the signature conference of our Bangalore. So I request all our listeners to participate and make it into a huge success. So request all my listeners to submit their valuable work to Journal of Acute Care. So thank you one and all.